Welcome to the Downsized. My name is Laraine Durham, and I'm here with my husband of 22 years, Christopher Durham. And this is a series where we talk to doctors about GLP-1s, GLP-1 weight loss, GLP-1 care. And before we get started, we hope you will like and subscribe to our channel. Christopher and I are not doctors. Dr. Megan is a doctor, but she's not your doctor. So please consult your doctor before starting any weight loss or healthcare journey. Welcome, Dr. Megan. We're glad to have you here today on the Downsized.
Yes, thank you so much for having me. I'm delighted to be here and talk about these medications, which have really changed so much, I feel, in medicine, and much more to come.
Well, so before we jump into that, tell us a little bit about you. Give us the personal rundown.
Yeah. So I started my journey in medicine as a family medicine physician, and I still do some primary care, but I became obesity medicine specialized about 3 or 4 years ago now. And looking back, I always wanted to be able to help support obesity treatment and weight management in my patients. Of course, we talk so much about obesity as being sort of a leading cause of diabetes, heart disease. You can kind of think of it as the symptom that comes before everything else. And it's not that it's always associated with those problems, but there's so much that we can do to help prevent major disease. But really, in medical training, including in my own journey, I just wasn't able to learn very much about it for such a long time. Our medical training is very much focused around disease states and recognizing what's normal and what's disease, and really not a whole lot in between. And so the amount of education that we receive related to really truly health and nutrition, prevention is so minimal. And I really felt that was a shortcoming. So I was really excited when I had the chance to study obesity medicine and really dive in further to learn how could I help to support my patients. And that was really even before, much of the forefront of the current GLP-1 medications came about. So it's really been an exciting journey. And I'm glad to be here as part of the solution.
Absolutely. So you're dual board certified, right? So
That's
what
correct.
are the two?
Family medicine and obesity medicine.
And you're a certified coach. So we'll talk about that more later. But
Yeah.
I know you talk about you're a recovering perfectionist and getting it right. And certainly for those of us who've been battling this obesity thing, I think a lot of us face that. Talk about the importance of that to you.
Yeah. It's such a loaded topic, really. I grew up in the 80s and 90s. I'm an elderly millennial. I'm the oldest kind of millennial, if you look at where the cutoff is. And growing up at that time, we had a lot of diet culture that was out in the media, as well as this explosion in processed foods. And so much of what I read as a young child, flipping through my mom's magazines or seeing on TV was all about really controlling women's bodies and how women's bodies should look. And there was certainly some about male bodies, but there's certainly a much higher degree of control and perfectionism around women's bodies and the way that they are supposed to look. When you grow up in that and you see the way you're supposed to look, and unfortunately those women were often pretty unhealthy to be as slim as they were, that really creates a lot of issues around eating and restriction and interestingly, I find a lot of people who grew up at the time that I did suffer with binge eating disorder, which is alternating cycles of usually binge and restrict. It doesn't always kind of fall to the full criteria for binge eating disorder, but a lot of the time it really does. And it all ties around this perfectionist idea because we were taught during that time, well, you just need to restrict your calories. Doesn't matter where those calories come from. It doesn't matter the quality of those calories. It doesn't matter if you're fueling your body. You just need to cut them down. And when we do that and we get really rigid and tight, most people will tell you, my mental space is very, very negative and unpleasant because my body is sort of like my brain is beating my body up into, suffering through hunger and telling yourself all these terrible messages, which is that kind of perfectionist side. Well, at the meantime, sometimes we say, well, screw it, let go. I'm just gonna go and do what I want to do, right? And then we fall into more of a binge cycle. People think about perfectionism as this affirmation, right? This like aspirational goal of like, oh, well, isn't being a perfectionist good? But it really has this shame avoidance quality, right? I don't want people to see that I'm failing. I don't want people to see my struggle. I want to look like I'm doing everything perfectly well. I want to look perfect. I want to have this perfect body. I don't want to ever say the right or wrong thing. I don't want to make the wrong choices. I just want everything to be just right. It is a terrible negative headspace. And there's so much alignment with disordered eating and eating disorders that it's really hard to sort of tease those two things apart. So whether we're talking about food and eating and bodies, or whether we're just talking about, where perfectionism and sort of black and white thinking and this negativity comes, like the overlap there is just really tremendous.
I can certainly relate to that because I'm a little bit older than you. So I grew up 70s, 80s, and 90s, and the Kate Moss and the stick thin and the having to be restrictive with the eating all the time, and restricting my eating so much during the week. Like I could really get it down during the week, right? But come the weekend, like all bets were off. Let's go out. Let's eat dinner out. Let's have a few drinks. Let's, all the things. And so it was just that kind of rinse and repeat cycle over and over.
Yeah.
And it was almost like, with the perfectionist thinking, if I blew one snack or meal,
Yeah.
the whole day was ruined. The whole
Right.
day
The
was, the
day,
month
the
was
whole
ruined.
week,
I'll
the
start
month.
on Monday. I'll start
Yep.
next week. I'll start
Yeah.
on January
Yeah.
1st. So
Yeah.
yeah, I can definitely relate to that.
Yeah.
Well, so there was a lot packed in there, right? You kind of had the whole mental state, the physical perception, the packaged foods and processed foods. And I'm interested, how do you approach obesity care? Because for so long, there's always been a boogeyman around. It was fat, it was
Yeah.
processed foods, it was sugar, it was whatever it was. And you obviously just said three things that all impact it, and we all know there's
Yeah.
a lot more.
Yep.
So how do you approach obesity care knowing that it's truly a multifactorial, unique thing for each individual?
Yeah. That's a loaded question too.
No, I know.
When patients are coming to see me, especially for a weight management intake appointment, so they are scheduling that on purpose to come and talk about their weight, their eating, their health. Um, that conversation ends up being a lot easier. And I have a pretty extensive questionnaire that I send out to them beforehand. And it goes through health history and some of the standard questions, that we want to ask somebody, but it also asks a little deeper of, are there times that you overeat and feel physical or emotional discomfort afterwards? Do you have frequent food cravings, food thoughts, food noise, food chatter? You're always thinking about food. Are you always hungry, even if you've just finished eating? Those three questions are really hallmark for me because it really helps me to tease out, right? It helps me to tease out, all right, where do we have, kind of struggle around eating? And sometimes people say no to all three, but that's pretty rare. There's usually at least one thing that's in there because, again, we have so much disordered eating of different stripes. We have some people who are always hungry no matter what. They feel a sensation of physical hungry no matter what. And there's probably metabolic imbalance there. Sometimes people are doing all the right things, right? They're eating a relatively healthy diet, they're exercising, they're trying to pay attention to all the things, and the weight is still climbing. And often there's metabolic imbalance there. Sometimes there's binge eating disorder that hasn't been talked about. And they might have that pattern, right? Of like, I can sort of hold it together during certain periods. I can hold it together all day. But then I have these recurrent episodes where I just kind of go off the rails. I'm intensely, intensely shamed about it. And I don't want to mention it. That's often the first conversation that someone's had about that eating behavior is when I ask. And I try and really create a safe container for us to talk about it because, again, there's so much shame. And in part, right, that comes from society. In part, it comes from messaging from diet culture of you should be able to do this. You just need some willpower. And it comes from, the medical community who, have told people this should be easy. It's calories in, calories out, the biggest lie ever told, right?
Right.
And people should just be able to figure it out. If I'm being told that, I'm not going to disclose that I'm really struggling with my eating at certain times and I feel really out of control, right? I'm not going to bring it up. So asking those questions in advance of the appointment
Hmm.
helps to sort of open the door even before people have come in to see me, right? So they're already kind of thinking about it, and then they're pretty open to having a conversation. So that is the person who is actively seeking out this care, actively recognizing that there's some problem, and I've kind of expanded the way that they're thinking about, kind of what's going on with their bodies. Um, we sit for an hour. We talk through, kind of all the different facets that have contributed. I talk about what was conversations about bodies and eating growing up in your household. Were the adults in your life kind about their bodies? Were they always dieting and, kind of hating their bodies? And, kind of what were those factors that went into it? What happened during the pandemic? What happened during other, milestones in your life, like after having kids or graduating from college and going out into the workforce? There's so many things that can trigger episodes of weight gain or disordered eating. So we really dive into all of that. Of course, we do metabolic assessment. We do some blood work and try and look and see in kind of a deeper dive than I would do as typical in a primary care office. Really trying to tease apart what are all the elements here so we can come up with a treatment plan that is really helpful. I think those conversations are very open. I think I get a lot of information from people that really helps to guide. And there's a catharsis there of being able to talk openly in a shame-free environment about what you're struggling with.
Yeah, what a great environment to be able to talk with a medical professional, right? Because by asking those questions, you give the patient permission to think
Mhm.
about it and talk about it openly, where before it's been like, oh, there's something wrong with me. I don't have any willpower. I've been exercising and I can't get this under control.
Right,
So
or
I,
people have not been believed, and
yeah,
I see that quite a bit as well. And I was at a medical conference in November, and there was a speaker, who went before me, an endocrinologist, and, he was just kinda shrugging his shoulders, and he said, "Patients lie to you all the time about what they're eating." And
well,
and,
maybe.
it's like, it's true that I think a lot of us have a misconception of like how much food we are or not eating. And a lot of people don't track for a lot of different reasons.
Yeah.
Um, but just this attitude that patients are always lying to you is so I was on the stage because I was going to be speaking after this gentleman, and I
Yeah.
just was like, oh, neutral face, neutral face. Because
Yeah.
this
I
is
mean,
wrong. This is
I
part of the problem.
I mean, as someone who has, food journaled and then had to present it to a doctor type person,
Right.
maybe I wasn't always the most honest about
Sure.
everything that I ate, and even at Weight Watchers, when it's just me looking at my tracking,
Yeah.
I didn't write down everything that went in my
Right.
mouth, but I wasn't
Were you trying to
deliberately
gain
trying to
something?
be
Were you like,
dishonest.
we were
Right, no, it was
like
more of
yeah.
a mental struggle on my end than intentionally trying to deceive, so I appreciate your
And this is the only healthcare that people have to earn.
Yeah,
Right,
Nobody
right,
told a diabetic to go run a marathon before we would give you medicine.
right, right. Well, and even still, we'll talk about insurance coverage, right?
Yeah.
It still asks, has the patient participated in at least 6 months of, lifestyle measures, and are you incorporating, nutrition and activity in their plan? And it's like, yeah, yeah. Yeah, because, and I'll be kinda it's all over the map, but it's very few people who show up in my office, who haven't tried something, and
right,
I'll say again too, it's kind of much more the women who have been socialized into, diet culture and control of bodies and judgment and shame, and, they're often caregivers and do all this unpaid labor.
yeah,
Um, that person has usually been off and on attempts for a long time. to, control their bodies, to keep it together, to restrict, to have willpower. There are a few people who show up in my office and they've not tried anything. They really truly don't know what to do. But that's pretty rare.
So when did GLP-1s come into the conversation with you and your patients?
Yeah, I started to really use them starting around 2022, 2023. I'd say 2023 is really when it rolled out, and that's when we had Wegovy coming out. People were using Ozempic off-label. Ozempic is the brand name product for semaglutide. Ozempic is the diabetes version. Wegovy is the weight loss version, and we can talk about why do we have three names really for this drug.
Don't forget Rybelsus.
Right. I do forget about that one because I don't tend to use it very often, but
Yeah.
you're right. We do have an oral version as well. And there'll probably be a weight loss version that comes out that will have probably a different name. Rybelsus is the diabetes name. But 2023 was really when, we had this real major uptick in the availability and the ability to prescribe Wegovy. So I wasn't really doing the Ozempic, nothing wrong with it. It's just there was this window of time where sometimes people who didn't have diabetes were able to get Ozempic because people noticed, right, it was so tremendously helpful for weight loss in people who didn't have diabetes. And for a while, insurance companies weren't really paying attention to it. They were just like, oh, that's fine. We'll pay for it. And then they figured it out and everybody got kicked off their Ozempic. And you probably know some people who've shared stories about that. They suddenly lost coverage for it. And the insurance companies, well, they don't have diabetes. And it's like, we never said they did. We never said they did. It's just a tremendously helpful medication. And off-label is not illegal.
Right.
Off-label use of medications just mean this is not the original FDA indication for this medication. So Ozempic was approved to treat diabetes. They had to come out with a different medication name, Wegovy, for the weight loss version. And that has to do with the fact that obesity is not covered as a standard part of insurance. It's a complete carve out. So employers can opt into coverage for it. But because the manufacturers of these drugs knew this, right, they're like, we're going to have a diabetes name and a weight loss name because the coverage for these two things is going to be very different until Congress changes the law about what has to be covered in health insurance. It's just a wild, crazy story of like, how did we get here?
And in other countries, they don't have two names.
Nope.
Well, and I don't think I realized that the drug company did that based on the insurance companies.
Yeah.
I thought it was more like a access issue. Like we want the diabetics to be able to get theirs. We want the
There was
weight loss
talk
people
about that, especially when there was shortages.
Yeah.
And there was this concern of like, oh, well, how dare anybody use this, for weight when people with diabetes need it. And, I understand that line of thought. And preventing diabetes, I would say, is as important, if not maybe more so than treating diabetes. Like both are important.
Yeah.
And so I don't know. I kind of let go of that mentality. But no, I'm pretty certain that it actually comes from they knew that the coverage would be way different.
Well, there's
knew
some
that-
patent implications too. So they keep,
Absolutely.
I think Novo's got 100 patents or something around semaglutide, and each time they get approved for a different indication, it changes the patent length on things and
Yeah. Yeah.
our crazy law system.
Yep. Yep. There's so much money on all sides of things. I mean, that's just the reality. And it's also very interesting that, if we really sort of step back and think about what's happened in the world, in the last 40 years with, again, with this rise of processed foods, all the low fat foods that were so popular in the 80s and 90s and diabetes and obesity, right? The SnackWells, and all the diet, everything. The explosion of diabetes and obesity that, really came out of that. And the food companies make a tremendous amount of money and they spend a tremendous amount of money trying to, design these foods like, that we'll just keep eating, that don't fill us up, but they're very like satisfying in our mouth, right? Like crunch and taste and just the right flavor combination, right? To just keep us eating until the bag is empty. They make a tremendous amount of money. And now we have these drugs that cost a tremendous amount of money to treat for some people what is, I'm going to call it processed food addiction,
Hmm.
right? If you think about binge eating disorder, we now have that name for it. I would say a lot of the time it's actually processed food addiction because nobody is
Yeah.
binge eating broccoli. Nobody
Right.
is,
Nobody's
like
binge
really
eating apples.
overdoing.
Yeah.
Right. There's limits to how many of those foods you can put in your mouth just because of the way that
Yeah.
they take up space in your belly and fiber and all of those things.
Hmm.
But let's not ignore the fact that there just is a tremendous amount of money, and now the food companies are trying to market products for those of us on GLP-1s,
Oh,
right?
yeah.
So they're just kind of like chasing us around and around, and it is what it is. But
Yeah.
knowing that cycle, I think, doesn't mean that we shouldn't use these medications. It's like, no, let's pay attention to what's going on in the food industry, and let's also not leave out
Absolutely.
the people who currently have a problem.
I mean, the
Yeah.
reality is 74% of America has overweight or obesity. So
Right.
the problem already exists.
Right. Yeah.
So how do you treat the problem? And then how do you anticipate the problem and fix
Right.
the food system at the same
Right.
time, not
Right.
one or the other? Somebody commented today, oh, well, if you just get rid of high fructose corn syrup altogether, there would be no obesity. I'm like, well,
That
that's
would
a
be
little
a
bit of an
start, but it's
oversimplification.
not just high fructose corn syrup. I mean,
But
Yeah.
it's not doing us any favors for sure,
Right.
but
I'm like, absolutely, you should do that, but that's not the only thing that's happening
right,
here. We
right.
also have a sedentary society. We also have screens.
Yep,
We have
yep.
all these
Gonna get rid of
things.
Doritos.
Right, right.
I don't
Take
think
down
so.
the Doritos industry.
Yeah. Well,
Yeah.
when we talk about super palatable, highly processed foods,
Yeah.
Doritos is always the first thing I think about. So, getting back to working with patients on GLP-1s,
Yeah.
Wegovy versus Zepbound, when
Mm.
are you prescribing those for people?
Are you talking about one versus the other or either
I
medication?
mean, maybe both. Yeah.
Yeah, yeah. I prescribe those medications when it's clear to me that somebody would benefit from them and we have some avenue to get through the cost. So that might be insurance coverage for people. And I work with a fantastic person in my office who does a great job helping with the prior authorizations. Unfortunately, there's a little bit of an art to it. Unfortunately, it's a little different for each employer of
Mm.
what are their criteria, and we've learned a tremendous amount together. But if your employer does not offer obesity medicine coverage, there's generally no arguing with them about it. It's often a really hard stop. And that's something that patients don't understand. They're like, oh, my doctor just didn't do a good job of advocating. It's like, no, if your plan excludes medications used for weight loss, and
Yep.
you don't have one of the other indications, such as heart disease, such as sleep apnea, and we'll see more indications, coming out over time. If you don't have those things and you don't have coverage for weight management, it doesn't matter how many times I contact your insurance company, they're
Right.
not paying for it.
That's what happened with us.
Right. It's just, that just kind of is the reality until Congress changes the law, until employers start seeing the value of offering, this kind of coverage to their patients. So if patients have an avenue either through their insurance or they are able to afford some of the discounted, I only use the brand name products, so we can talk about that, but discounted Wegovy or Zepbound through one of the patient assistance programs, and they want it, then that's the route that we go. But we also talk about other medications such as Metformin, Phentermine, diethylpropion. There's kind of a number of medications, and I often will combine things. And many obesity medicine physicians do that as well. Of like, we're going to combine something that targets metabolism. We're going to combine something that targets appetite suppression, so that we've got a combination of effects depending on what the patient is experiencing. Patients obviously have to be willing to inject themselves. The injectors are generally pretty easy. We do have Zepbound in vials now, so people draw it up in a syringe. And patients are pretty motivated and comfortable to do that once they sort of get past the mental block. But I do
Yeah.
use these medications quite a bit. As I said, there might be a weight loss version of oral semaglutide coming out. I know there are compounded products that are that way. We have Rebelsius, which is for diabetes. The molecule, as my understanding, is that it's a little bit tricky to absorb orally, and so it's kind of
I
fussy
think that
to do
pill
it
just
that
got
way.
approved for 25 milligrams. Yeah. So,
Yeah, and I've seen doses up to 50 of the
yeah.
oral, I think
Yeah.
was studied. So we'll see. We'll see what happens with that. And then thinking about Wegovy versus Zepbound, sometimes there's coverage difference between the two. Sometimes patients have indication for one versus the other. So we've got heart disease indication for Wegovy. So that fits a lot more of my Medicare population. We've got sleep apnea coverage for Zepbound. Those rules are real fussy. I find that there's a lot of variation in how it's not just having a diagnosis of sleep apnea. It's usually like it has to be a certain severity, or you need to have, daytime symptom, kind of a variety of different things that go into the coverage. Um, and sometimes I'm thinking about what degree of weight loss might this person need. So Zepbound does appear to be a little bit more powerful. And so if I've got somebody who has, pretty significantly high BMI, I might reach for Zepbound before Wegovy, but those are the kind of the things that I'm thinking about as we go along.
We get
Gotcha.
asked the question all the time, and I'm like, talk to your doctor, see what your insurance covers.
Right.
And if you can get it for $25, the answer is that.
That's the
Whichever
one.
way.
Yeah.
Yeah.
And, between the two, like I have people who prefer one over the other. I mean, kind of for better or for worse with the shortages and
Mhm.
all the supply issues that have gone on. Sometimes people have had to flip from one to the other. We've gotten really good about being able to do that safely for people. And when there's no supply issue, when there's no cost difference between them, people will tell me, I prefer this one. And it's not always one side or the other. And, molecules, medicines, things land differently in each of our bodies. No problem there.
Interesting.
So I know you did a LinkedIn post kind of speaking to doctors talking about compounding. So what do I do with my
Yeah.
patients if compounders go away? Talk to
Yeah.
me about that conversation.
Yeah, it does get tricky, and there's a lot of different opinions as with anything else. Um, I follow the Obesity Medicine Association's recommendations not to use compounds, and not everybody agrees with that. And again, it's a conversation of there's money everywhere, and let's not pretend that one side is automatically better.
Everybody's making money.
Everybody's making money here. Um, from my mind, I can't effectively vet compounding companies to be able to know that people are getting legitimate product in the amount that it says that they're supposed to get, and without contaminants or things that really shouldn't be in there, or forms of the medication that may not be effective. Now, my experience in sort of observing people is there are some people who've responded tremendously well to compounds, don't seem to have any issues with them. So that compounding pharmacy is probably doing a good, legitimate job in being able to formulate that version of it. But there's a lot of people out there who are not being so careful. We've seen more adverse effects. We've seen more, issues with the compounded products. And I don't have the time, knowledge, or ability to go out and vet these companies. So I
Yeah.
choose not to do that.
I mean, that's
Um,
that's fair. I mean,
yeah.
as a doctor, you're staking your whole
Right.
reputation
My
there, right?
malpractice
That's
also,
yeah.
malpractice sometimes would not cover me if I
Yeah.
chose to use compounds. And so there's a lot of reasons why somebody might choose not to endorse compound products.
Yeah.
As compounded products are going away, we've seen some continued shifts in the market of, okay, well, the costs of these medications, continues to trickle down. They are still very expensive, but Novacare, Novo Nordisk's direct pharmacy with Wegovy has dropped the price to $4.99 per month for all of the doses of medication. So if somebody has no coverage for the medications, with some carve outs of they're not Medicaid, they're not Medicare, they're not TRICARE, so our federal insurances, then they are able to get that price. Zepbound recently readjusted their prices for the vials. So again, through their direct pharmacy, you can get doses 2.5 through 10 milligrams in vials for $4.99 a month as well. Again, with those same, actually, they don't have the carve outs for, I misspoke there. They don't have the carve outs for the not Medicaid, not Medicare, not TRICARE. That's the manufacturer coupons that are through the
Right.
commercial pharmacy. So if you bring a
Just strictly a
coupon
cash price.
to your
Yeah.
Walgreens, it's $650, but if you have Medicare, you can't get that
Can't.
discounted
Yep.
price, but you can
Yeah.
actually go through the direct pharmacies now.
And Lily makes you keep ordering or the price
And they
goes up.
make you keep ordering it. So people ask all the time, well, can I just split up the doses and make it last a little longer? You can probably get away with that for a little while, but essentially it's just not going to work out. People talk about stockpiling of like, well, I'm just going to order a whole bunch of the 10 for a while. Issues with that is that eventually often people will end up on higher doses. And so eventually that usually doesn't end up working out financially. It's still usually going to be around that $500 a month. But kind of speaking more to your question, so people who have come off the compound, so sometimes people are paying near that much money for their compounded medications, and they decide, you know what, my benefit of these medications is enough that I'm going to choose to find a way to pay for that. I do see that a lot more insurances and a lot more employers are starting to offer coverage. I live in Seattle, right? I have a lot of tech workers in my community. And so more and more coverage in, I'll say, some segments of the economy, because it's certainly not ubiquitous to all. So there's that. And then I think we're learning over time, and we will continue to learn without the benefit of big trials. If somebody has lost their weight with a GLP-1, are we able to move them to something else, something that is not GLP-1 and able to maintain? Usually when people have gone on medications to lose weight, they will usually need something to help maintain that weight loss, right? You can't just use these medications for 6 months and then go off of it. Most people will regain the weight because of the way that our bodies work. Our bodies want to regain that weight and protect us from famine. So I have people think of like, I might not be on Wegovy for the rest of my life, but I do want to think I'm probably committing to being on something for the long term here. And it's the same conversation of we're thinking about, okay, you've lost your compound. Maybe you can't afford to go on one of the brand name products. What else can we do to, get as close to mimicking the effects of appetite suppression, metabolic support, in order to help you be successful in the long run? Because that's what it's about. It's not just we lose the weight and we're done, right? Maintenance is a challenge too.
What are some of the names of some of those that I can ask my doctor about?
Yeah, so I use a lot of a medication called Metformin, which is an
Oh.
old, cheap diabetes medication that really helps with insulin resistance and sort of keeping blood sugar balance there. And then I often combine that with a stimulant medication to lower appetite. So that would be Phentermine, which is an old, cheap medicine as well. Diethylpropion, which is a cousin medicine of Wellbutrin. Doesn't work that well for depression, but it does work for appetite suppression. Qsymia is a combination of phentermine and topiramate, which is an anti-seizure medicine. That combination has some pretty strong appetite suppression. So there are combinations of things that sort of might get to some of the similar parts. I call metformin plus phentermine is kind of the cheap version of GLP-1. It's not quite the same, but I've had some people do tremendously well with that combination because it's hitting the right buttons in their body.
Can phentermine go long term? I mean, I had a doctor tell me
Yeah.
3 months was a max.
Yeah.
for me.
So the original FDA approval for phentermine in 1959 was for 12 weeks of use, so 3 months of
Yeah.
use.
Yeah.
And no one ever went back to the FDA to change that. Now, we do have Qsymia, which includes phentermine and has been approved for long-term use. That's a much, much newer medication out I don't remember, sometime in the last 10, 15 years.
Yeah.
And we've had some other versions of phentermine, including the short-acting, which is called Lomira, I believe, that have been approved for long-term use, but nobody went back to correct the original 1959 FDA approval because that costs money to do. So you'll still see it pop up on insurances. Well, we'll approve it for 3 months at a time. And the way that they played that for a long time is people would go on it, they would lose weight, then they would have to come off of it, prove that they gained weight to go back on it. And it was this constant game. But we've had people who have successfully been on it for many, many years. They've done fine. The same way we treat ADHD with stimulant for years, and people do fine. Yes, we need to watch blood pressures and heart rates. It can raise it a little bit.
Yeah.
We wouldn't use these medications in somebody who has active heart disease, chest pain, certain situations. But we've got lots of long-term safety. It seems safe and appropriate. I do warn my patients, you're going to get a notice. If it's covered by your insurance for 3 months, you're going to get a notice that it's not covered, but it's cheap.
It's cheap. I don't think I was covered for
Maybe
it, but I
20,
think it
20
was
bucks.
like $6 or it was
Yeah.
it
Yeah.
was very cheap. And it was something that I tried prior to
Yeah.
a GLP-1.
Yeah. Yeah. As
So I know
many.
you have a hard stop. So we'll ask another question and
Yeah.
be done. First of all, tell us about your podcast.
Yeah, so my podcast is called Ending Physician Overwhelm. So we touched a little bit on my coaching work. I coach primarily women physicians on the intersection of perfectionism, people pleasing, lack of boundaries with burnout. We talk a lot in medicine about burnout and all the systemic factors that go into it. We don't talk enough about how medical training and socialization as women leads us to having people pleasing habits, perfectionist habits, lack of boundaries in order to feel like we are keeping up with the expectation that so many people have of like, well, a man, a white man is the physician, right? That's kind of the model, the Marcus Welby, sort of ideal that we have in our heads. And unfortunately, racism, sexism is still, quite prevalent in the minds of not only patients, but also the healthcare system. So many of us have adopted these perfectionist, people pleasing habits that keep us working even harder inside a broken healthcare system. So my coaching work centers around that. And the podcast is really a way for me to share ideas with people about how do we unlearn these habits? How do we find our way to start setting boundaries and taking care of ourselves so that we can stay in medicine, so that we can continue to do the work that we enjoy doing, but without it always being at the cost of ourselves. It's really mind blowing how many people leave medicine each year, and especially during the pandemic, because of all of the intense pressures to always do more, always see more, always have a smile, never take a sick day. Don't ever have a bad day. You just have to be on all the time, and it's really an undoable task.
Sounds like a good podcast for most women to listen to, not just physicians. I'm gonna check
I
that
do
out.
get, well, you should speak more to, just women in general or women, and I'm like, I hear you. You can listen to. It's, there's no
Yeah.
there's no rules about it, but I'm speaking
Yeah.
to the women physicians that I have direct experience with being that woman and helping to guide others through, there's a life on the other side of like, we can unlearn these habits and we can do good work in the world and stay in medicine, but with a really different lens and being better able to take care of ourselves.
So finally, and it's a big question, so you feel free to answer, is
Yeah.
I know you're passionate about systemic change and really getting things to move in a way where it can create a healthier
Yeah.
us world, the whole 9 yards. Talk to me about that.
Yeah. I think that I spent a lot of energy in my 30s as a working physician, having, a couple kids and really just kind of railing against, how unfair it was, the ways that, the system sort of came down on us. And I was both struggling to try and do my best and sort of keep up with all the expectations that were placed upon me in those roles, but also saying, hey, it's not fair to constantly ask more and more and more of me and constantly be telling me to sprint when really I'm running a marathon here, right? The journey of a career in healthcare is a long one, and we need to be able to sustain it. I will say that I found that I was not the effective voice sitting at the table in meetings, being a part of change from the inside. And so I decided for myself that where I could have the most impact is being on the outside and being able to talk to the individuals, talk to the physicians who are out there doing the work, and really trying to help them see that if you take care of yourself, if you learn to set healthy boundaries, and are able to stay in medicine, we will change medicine from this direction, from the people who are actually on the ground doing the work, rather than waiting for that top-down approach, which, I saw dangled so many times of, we're going to focus on, the health of our healthcare teams. We're going to make all this better. But the way that medicine is set up, the business of healthcare, all has to do with driving the workers harder and harder and harder.
Mm.
As a physician, it's me seeing the patient and writing a note and dropping a bill that makes the dollars flow. It doesn't matter how many nurses I have helping me. It doesn't matter, how much support. It's the prescriber, the billing, provider dropping the bill that makes the dollars flow in the
Okay.
hospital, in the clinics. And until we get away from that model, that, still that kind of traditional fee for service model, the economic pressure is always going to be there to do more, see more. And it is burning through not just physicians, not just other clinical providers, not just nurses, like everywhere. It's just such a pressure and stress. And so
Uh,
teaching those
I,
people how to do it.
I think we've all been that patient who the doctor came in and really didn't look at you or pay attention to you,
Correct.
and
Right.
wrote down something or typed it on their pad or whatever, and they
Yep.
were gone in
Yep.
2 minutes.
minutes.
Yeah.
It is a product of functioning in an overworked system that never lets you feel like you're doing enough,
And I mean,
over years.
I can draw so many parallels with women executives, right? Being pushed to do more, to,
Bring cookies to the potluck, right? And be nice
right.
and be nice.
Right. You've got your maybe you work outside the home and maybe you have 3 small children and maybe you're trying to do something with the PTA and maybe your boss wants you to spend the weekend doing this extra thing. So,
Right.
it's definitely something as women we definitely need to rail against and
Yeah.
and figure out ways to cope with.
Yeah.
So,
Agreed.
in closing, if there's somebody out there thinking has an obesity or overweight problem and thinking about GLP-1s, what would you tell them?
I would tell them, get information from somebody who really knows what they're doing, who is able to guide you with compassion, knowledge, and who is there for you to navigate if there are issues. These medications are by and large very safe, but there's some things that can be done wrong. And so I just think it's helpful to be able to partner with somebody who knows what to do and how to guide you so that you can be successful, and then it will do what we want it to do. Yes, weight loss, but also helping to reduce your cardiometabolic risks, the risks of heart disease, diabetes, all those things that we really care about.
Awesome.
Very good. Well, thank you, Dr. Megan, for joining us today. It's
Mm.
been a great conversation. We'll close up. I'll leave a link to Dr. Megan's podcast and information in the description. So if you want to check that out, please go do that. I think you have a YouTube channel too, don't you?
I have 2 YouTube channels. Yes, I have one where I talk about weight and obesity medicine primarily, and then I have another podcast that is more for my coaching work and the
So we'll
podcast.
put the links to all that stuff in
Yeah,
there so people can go
great.
check that out. We appreciate it if you haven't already, like and subscribe to our channel as well. So
Amazing.
that'd be awesome. And that's us for today. My name is Christopher Durham,
I'm Laraine Durham.
and that's Megan. Thank you.
Thanks, Dr. Megan.
Yeah, thanks so much.